Hi, my name is Jessica Boyd. I am a clinical biochemist at Alberta Precision Laboratories in Calgary, and I'm also a clinical associate professor at the Cumming School of Medicine at the University of Calgary. Today, I'm going to be giving a presentation on laboratory testing for opioids with some discussion on interpretation and different technologies, and then how we can use some data mining techniques to help customize panels for clinics in your area. So just briefly, my objectives, as I mentioned, are to discuss the clinical laboratory and the impact that the opioid crisis has had on us as lab professionals, discuss the important factors in setting up a urine drug screening program with emphasis on the opioids, and then compare the available techniques for urine drug screening for opioids and the challenges that each of those technologies present. So, of course, the opioids are a very diverse class of drugs that are used clinically for analgesia and for opioid agonist therapy. They are anything that's an opioid is something that can interact with the opioid receptors in the nervous system, and they come in three kind of flavors: mu, kappa, and delta. And depending on those drugs' interaction with those receptors, you can have different impacts, different types of effects. Of course, we know that people who come in with acute opioid poisoning will present with a particular toxidrome, some of the features that I've listed below, but of course we know that in high enough doses, that type of poisoning is fatal, and that is really what has precipitated the opioid crisis that we're seeing today, especially in North America and where I am in Canada. Of course, this story started 3 or 4 years ago, when, particularly in Alberta here, for example, we started to see things like this show up in our illicit drug supply. So on the left-hand picture, we have a picture of what a normal OxyContin 80 milligram tablet would look like, and you can see it's green. It has an 80 stamped onto one side, or at least these are the ones that we get anyway. And what we started to see in Alberta, and what was being seized by our local police forces, is shown in the left-hand picture, which are very similar looking tablets. They have the same kind of stamping, the same coloration, the same look to them, but they don't have oxycodone in them. They have fentanyl, and fentanyl is much more potent, and so this was leading to a large number of people, unfortunately, passing away because they were taking a drug that they weren't anticipating in their drug supply. And so this has been, the opioid crisis has hit us in Canada very hard, and I'm going to show some statistics of what opioid poisoning hospitalization rates have looked like. This is data from 2017, but this certainly has not resolved in the past 3 years. And you can see that this has touched every corner of our country, and it has touched other countries as well. I know the United States in particular. Where I am in Alberta, which is towards the western side of the country, we have seen particularly high rates of hospitalization. Vancouver in BC has kind of been the epicenter for Canada for this crisis, and that's definitely reflected in these hospitalization rates. And if we were to dig down into these numbers, you would see that this is also something that's predominantly affecting young people, so people in the 15 to 40 age group. So, of course, one of the big pushes for the last 5 years has been to try and get identify these individuals and get them into a treatment program. And in the province of Alberta, our provincial government has put significant amount of resources into increasing the number of treatment spots in opioid dependency programs. And so that has had a very positive effect. And one of the side effects, I guess, of that is that we are seeing increases in prescribing of drugs like buprenorphine or Suboxone or methadone as these patients enter these treatment programs. And so this graph is showing a steady increase in Suboxone dispensing in Alberta. And this is a trend that is continuing into 2020. And this is probably what has a bigger impact on laboratory testing, because of course these patients are typically monitored through urine drug screening to ensure compliance as part of their program. So in terms of the laboratory impact from the opioid crisis, and these are ones that we felt here in Alberta, but I know that are not exclusive to us in Alberta, is we saw a huge increase in requests for urine drug screening starting in about 2015, 2016. And I'll show you some data later about what exactly that looked like and show you some of the strategies we took to try and address that, considering that I'm sure we're all in a resource finite environment and there isn't money necessarily to hire a whole bunch of new staff or always get new instruments all the time. But it wasn't just an increase in the number of drug tests that we were receiving, we were also getting requests for certain types of tests within the panel. So of course, one of those was fentanyl. Prior to 2015, we did not have fentanyl on our immunoassay panels, and we probably honestly didn't think we were ever going to have to really do it in large volumes because fentanyl was fairly difficult to get a hold of. You had to get it as part of a fentanyl patch or diversion from hospital supplies, and so it wasn't as readily available. Of course, as soon as powders started coming through the mail containing fentanyl, that definitely changed the situation in terms of what we needed to do. One of the other big changes was requests for buprenorphine testing. So again, 4 or 5 years ago, I would say 98% of our opioid dependency treatment patients were on methadone. The switch to buprenorphine has happened over the last few years as we try to, again, increase treatment spaces, increase the number of providers who can actually prescribe this drug, get people started in the emergency department when they're presenting. And so now, if we were to look at our data, we have actually more patients on buprenorphine than we do methadone. So that was also a major change that we had to deal with fairly quickly in 2015-16. So it's always good when we're talking about setting up or changing a urine drug screening program to have an appreciation for what kind of patient population we're looking at. And of course, with the opioids, there's several different areas that this can touch. So typically with opioids, I'm kind of thinking of 3 main areas for my local area. One is emergency departments, and this is one that often comes up in the news or the literature about, what do we do for them? And of course, they're the ones seeing patients presenting for acute opioid poisoning. And I think it's really important to remember that, while they may order a urine drug screen, they're actually not waiting for the result of that, or they shouldn't be. To be prescribing or administering naloxone if someone is showing up with an opioid toxidrome. And so in these cases, the urine drug screen may be helpful later to decide what exactly the patient came in on, but it's not actually particularly helpful for acute management. And so, we're not necessarily setting up programs to get results back right away. They've got an antidote and they should be giving that. So where we've really put our time and our energy is looking at what the needs of, for example, our pain management programs are, but particularly in my area, what the needs of our opioid dependency treatment programs are, because that's where people are moving to, hopefully, once they've presented to the ED. The needs of a pain management and an opioid dependency treatment program are a little bit different than, of course, the ED, because typically what they're doing is checking compliance of prescribed medications. Those prescribed medications are not necessarily the same between those 2 groups. Of course, for opioid dependency programs, buprenorphine and methadone are probably 2 important ones. But your pain management providers may be using a whole variety of things, and it's important to understand what they're using so that those can be on your panel. And of course, we always usually have some of the other commonly used drugs or drug classes, so benzos or amphetamines or whatnot, because we're also looking to make sure that they're not taking other things perhaps in addition to their prescriptions. So in terms of the laboratory process for drugs of abuse testing, this is a pretty standard process used by many labs. And it's usually a two-step process where we have some sort of screen using an immunoassay. And then depending on some sort of criteria, sometimes it's all positives, sometimes it's certain positives, then they go on for confirmation testing by mass spectrometry. In my lab, we have both of these technologies, so we're able to control in-house what goes where. I know there are many areas that do not have mass spectrometry on site, and it's an expensive referral test. And so controlling what goes out for mass spec is more of an issue. But I'm hoping to show you by the end of this talk why having mass spectrometry available for the opioids is important due to the limitations of immunoassay screening, and which is really is a screen and it is not a definitive result. So of course, immunoassays are present in many places, and as I mentioned, that they may be the only type of testing available on site. And there's reasons for this. They are pretty simple to perform. You can get the result pretty quickly, and they can be performed at the point of collection, and there are point of care programs set up for these. But it is really important to remember that immunoassays are prone to false positives, they're prone to false negatives, and within that test itself, it cannot tell you if that is a false negative or a false positive. We just know that there was reactivity with an antibody within the test. And so these results require confirmation by mass spectrometry. Otherwise, you can't tell whether this was something actually an opioid in some of these tests, which opioid, or whether it was something that's not an opioid but just happens to cross-react with the antibody. So this is the real strength of mass spectrometry for this type of testing. So I just want to take a few minutes and talk a little bit about opioid versus opiate nomenclature, because this is also very important for understanding the interpretation of these tests. Often opioid and opiate are used interchangeably, but they are not the same thing. And in this table, I've shown a kind of an overview of how they work together. So opioid is an umbrella term that refers to anything that can interact with the opioid receptor, essentially. And so everything in this table, and like I said, this isn't an exhaustive table, but all of these would be opioids. The opiates are in the left-hand column, and those typically refer to the opioids that can be derived from the opium poppy. So we're talking primarily about morphine and codeine. And I've put a structure down at the bottom so that you can see that they have a 5-ring structure with different side groups at kind of 3 different places on the backbone that change whether it's morphine, codeine, or a metabolite. In the middle column, we have the semi-synthetic opioids, and I've thrown things like hydrocodone, hydromorphone in here. Now, hydrocodone, hydromorphone are metabolites of morphine and codeine. But when we're talking about urine drug screening, we know that actually, despite being metabolites of morphine, codeine, they don't actually react as well as morphine and codeine in the urine opiates immunoassay. In fact, in our assay locally, for example, we get about 50% reactivity, meaning that we need twice as much of hydrocodone and hydromorphone in the urine to get the same response as morphine and codeine. And so that's a big source of false negative results, and why at my institution, if my staff see that a patient is on one of these, we actually just send it straight to mass spec. I put oxycodone here as well. Oxycodone may or may not react with your urine opiates assay. In ours, it doesn't react at all. But again, if the assumption is that a urine opiates assay reacts with all opioids, and it's not understood that it really is just taking out morphine and codeine, then that can be a perceived, I guess, false negative. And then in the right-hand column, we have the synthetic opioids. This includes things like methadone, fentanyl, buprenorphine. And these ones really, there is no reactivity in the urine opiates assay at all, and you need to have a separate immunoassay for testing for these. And you can see at the bottom, the structures are quite different. They don't even have that 5-ring backbone anymore. And so that kind of, visually can help us understand why that antibody may not pick that up. Metabolism is also really important to understand for urine drug screens because in urine, typically it's the metabolite that we're seeing at the highest concentration, not the parent. And so one of the most common calls I get is understanding how codeine, morphine, and heroin and their various metabolites go together on our drug screen panels. So in the middle, you can see codeine and morphine here. Codeine, of course, is a prodrug. Morphine is what we want it to metabolize to once you've taken it. I've already mentioned that both of those can also be metabolized to hydrocodone and hydromorphone. Those are at the top of the screen. They're minor metabolites, but they are active, but they can also be given as drugs themselves. Towards the bottom of the screen, we have the inactive metabolites and the glucuronides. So normorphine and then glucuronidated forms. And then on the right upper side of this diagram, you see where heroin can fit into this pathway. And heroin will metabolize to 6-monoacetylmorphine or 6-MAM, which then metabolizes to morphine. So in a urine opiates assay, I've already told you that it will pick up primarily codeine and morphine, but depending on your assay, it may have cross-reactivity with 6-monoacetylmorphine or heroin. And so the assay we use locally does pick both of those up. So this is another caution about acting on a urine opiates result, because if it's positive, even if it's a true positive, you don't know whether that positive is coming from codeine present, morphine being present, or heroin and its metabolite being present potentially. So again, why mass spectrometry is really important so that we can speciate those out and give that information to the physician. This is just a simple diagram for some of the other opioids that we're typically looking at. They're a little bit more simple than the codeine morphine group. So typically we're looking at, one parent, one metabolite pair. You can see that buprenorphine also has some glucuronides floating around there. And here just would point out that for methadone and buprenorphine, we actually monitor, even on our immunoassays, at least for methadone, both the parent and the metabolite. And the reason that we do that is because we're trying to pick up people who might be adding some of their methadone or buprenorphine to their urine in an attempt to fool the drug screen. And the drug screen, I guess, isn't being fooled. There would actually be methadone in the urine, but if it's present without the metabolite or without significant amounts of metabolite, it suggests that there was some adulteration of the urine. And so that's a practice that we've done for quite a long time locally for our opioid dependency clinics. So what immunoassays are available for testing of opioids in urine? So I've made a list here. This is not fully exhaustive, but it's there to give you an idea that there are lots of options, and you could put a whole bunch of opiate immunoassays on your chemistry analyzer. But it's going to start taking up a lot of room at some point. And so this is, again, back to knowing what your population is and knowing which of these tests are actually useful to have on your instrument. It is really important to note here that cross-reactivity is going to vary between the vendors. So make sure you take a look at the package insert and understand what your opiates assay, is it reacting with heroin and 6-MAM particularly well? Is it not? If it's not, you may need to have a separate heroin metabolite assay. What's your cross-reactivity with hydrocodone, hydromorphone, or do you need to look at having a separate immunoassay for that? Another thing to pay attention to are cutoffs. The opiates, for example, usually comes with two different cutoffs, a clinical and a workplace cutoff. And what you pick may depend again on your population and maybe also on your resources for sending out for mass spec if you don't have it on site. So this is understanding your reflex algorithm may also play a role in that as well. Now, because of all of the assays that we would potentially be looking at to put on our instruments, and the fact that we really at my institution didn't have room to put all of these on, and that these are all still, even if they're targeting, hydrocodone or fentanyl specifically, that immunoassays are still not definitive results So the decision that we did at our institution was to start moving all of this onto mass spec, to kind of bypass all the interpretive issues that we see with immunoassays, and also the amount of testing that we would need. And so we are in the process of, like I said, of discontinuing most of our immunoassays in favor of mass spectrometry. And the way that we've decided to do this is through liquid chromatography, tandem mass spectrometry, using targeted analysis with MRM, multiple reaction monitoring scans. So this picture in the middle here is a picture of a triple quadrupole, and it is in MRM mode. And if you don't know what that is, essentially what we do in the Q1 box is we tell the instrument to only allow the ions of a certain molecular, mass to charge ratio. So for example, we should know as part of method development what the mass to charge ratio of morphine would be. So we'll tell the instrument only allow the morphine mass to charge ratio through. Now, of course, there is a possibility that there is another molecule in that sample that has the same mass to charge as morphine floating around. If you've done your chromatography well, you may have separated it out already, but in case you didn't, the mass spec allows you another opportunity to filter that out. It does that by fragmenting that mass to charge in Q2 to produce product ions. And then again, as part of our method development, we would have identified the major product ions of morphine and told the instrument, okay, these are the top 2 or 3 product ions of morphine, and we only want that to transit to the detector at any given time. And so that will give us our MRM signal on the right-hand side. And so typically in any one of our drug screen analyses, we'd be monitoring at least 2 of these transitions per analyte. And we are able to do this simultaneously so that we can look at all of these opioids, and other classes of drugs at the same time. The downside of this, of course, is that if there is something going around in the urine that is not on your list that you've predefined with the instrument, you're not going to see it. And so this is definitely a downside, in that picking up new drug trends is difficult with analyzing your samples as well. But we made the decision to go this way because we had so many samples that we needed to get through, that it was more important to kind of look for the key ones, and then we would kind of work with our partners in the province to work on identifying new drugs that we may need to add. The other advantage of mass spectrometry, particularly if you're doing it as a lab developed test or an LDT, is that you can add new analytes yourself. It does require method development, and you may need to go muck around with your method to get it to work. But typically you can add those new analytes, if you can find a standard, a lot sooner than it would take for a new immunoassay test to be developed. If you've been paying attention to the news, we've seen over the last 5 years, several new drugs kind of start to show up in the drug supply, along with fentanyl. Carfentanil is an example. And that's one that we added to our mass spec panels. And I think I've only seen 1 or 2 little point of care devices so far for carfentanil. I'm sure people are working on it. So you can potentially move a bit faster on some of these new emerging drugs as well. So just to give you an example of what one of our opioid panels looks like, this has all of our kind of important parents and metabolites from codeine and morphine metabolism. We have methadone and EDP, buprenorphine, norbuprenorphine, oxycodone, noroxycodone, fentanyl, norfentanyl. And so the real power here is that you're able to monitor for all of these simultaneously in one sample. And so I can look at it and go, are the codeine or what we see in terms of morphine, codeine, norcodeine, does that look like a codeine pattern? Does it look like maybe they're taking hydrocodone, hydromorphone separately? And so it gives me a lot more information than if I'm just trying to decipher an immunoassay result for all of these. So in the last few minutes, I just wanted to show you some of what we've done in Calgary to try and address the our issues with the opioid epidemic. You can see here a graph of our workload volume and requests for urine drug screens between 2010 and 2017. And you can see that, prior to 2015, we had pretty stable drug screen requests. It was pretty much the same number, plus or minus, 5%. Very predictable. We had totally arranged our staffing and our instrumentation usage around it because, we didn't have any major changes. You can see in 2012, we did see an increase, but that's because we had a new clinic coming on board and we knew that was happening. So it actually made, it was fairly easy to plan, like I said, our staffing and workflow around this. But in 2015, but particularly 2016 and 17, as fentanyl started to show up in the drug supply in Alberta, we started to see those numbers shoot way up, and we actually saw a doubling of our volume over 2 or 3 years, which really threw our entire process out of whack. We were not able to keep up with the samples coming in. We had to start doing elaborate sorting processes to make sure that we were getting kind of ED and hospital samples out, and we would do opioid dependency samples later because that would take us probably 2 or 3 weeks. At one point, it was taking us 7 or 8 weeks to actually get those results out, which is starting to impact the management of those patients as well. And so we knew our process was not sustainable, needed some major changes. And so we went to the drawing board to kind of decide what we were going to do. And part of the decision at that time was to start moving all of our samples to a fully LC-MS process, a targeted panel. So we would, have 20 or 30 drugs on that panel. We would use automated liquid handling to extract our samples, which we were doing manually before then, and then we would get middleware to connect our instruments to the LIS so that we didn't have someone manually putting results in as we were doing in 2014. But part of the big question there was, well, what do we need on these panels, and are we going to have one panel for everybody, or are we going to have customized for certain user groups within our population? Because we do all the urine drug screening in Southern Alberta, so we cover everybody. And so what we did there to address that question was to do a retrospective data analysis of our urine drug screens to see who is ordering them, what drugs were we seeing commonly in our population, and I've got some of the summary information here. We did just over 50,000 drug screens over a 4-year period. That represented just over 12,000 individual patients. And on average, we were seeing just over 4 drug screens per patient over that time period. But of course, we had quite a big range on that. The majority of those patients were coming in with just one drug screen because they may have been in the emergency department or something. But then we would have a large cohort of our patients who were opioid dependency program members, and so were coming in regularly to have samples. And so we had one individual over that 4-year period who had over 100 drug screens. So definitely showed us that we had different groups within our population. So who ordered the most drug screens? When we broke it down by ordering provider, it was very clear, and I think we knew this before, that addictions medicine was the #1 requester, and the majority of those were opioid dependency clinics. And so we wanted to definitely work with that group to figure out how this process was going to work, because they also represented most of our repeat customers. So one of the biggest users within the addictions medicine group was physician A. This was the sole physician at the largest methadone clinic in Calgary. He had actually kind of spearheaded a lot of the methadone treatment more than 10 years before, and so was very knowledgeable and had been around for a long time, and so knew his patients really well. And he actually represented, his patient cohort represented a quarter of our total workload. So obviously getting him on board with any changes we were doing was extremely important. So I did as part of a data poll, I looked at what drugs we were detecting within his population, and so it's not really a surprise that majority of the positive drugs in his population was methadone, and at the time, as I mentioned earlier, methadone was the primary drug being used for opioid dependency at that time. And you can see that 88% of the specimens received from that clinic population were positive. Then looking down the rest of this list, and this is just kind of the top grouping, we see morphine, codeine, diphenhydramine, ibuprofen, oxycodone. And so we wanted, but the numbers are dropping off in terms of percent positive quite rapidly. And so, I had a very long list of things that, were less than 1% positive. And so we wanted to make sure we were pulling out kind of the really relevant, most commonly detected drugs out of his population for a panel. So what I proposed to him was this panel, which was an LCMS targeted panel that had, of course, methadone EDDP. At that time, his clinic wasn't prescribing buprenorphine, but we did add buprenorphine later. We have morphine, codeine, 6-mAm, oxycodone, and metabolite, cocaine, fentanyl, norfentanyl, amphetamine, methamphetamine. And so we went and met with him and said, what do you think? These are the issues that we're having. That moving to this panel would allow us to give you your results in a less than 1 week time frame, as opposed to the 7 or 8 week time frame that we were dealing with at the time. And so we had a really good discussion with him. He definitely understood the problems that we were facing, and he was definitely motivated to help us find a way to get his samples back to him sooner. He was also one of the big advocates for making sure that they could have access to LCMS, because he understood all of the issues with the immunoassay interpretation. And so he actually wanted all of his patients to go to mass spec if we could accommodate that. And so this was one of the ways that we said that we could potentially do that. We also discussed the data poll that we had done and presented the proposed LCMS panel and had a really good discussion with him about it. And so after that discussion, we ended up expanding the panel slightly to 21 drugs. We kept the opioids, amphetamines. We added a few benzodiazepines that he had said he was having problems with from his population, although, we are looking at the drug screen side and saying that, they're not detected often, but, it's the feedback of what the physician is getting from his patients or her patients is really important as well. We kept cocaine and added a few adulterants that were commonly seen in our population. We added a urine ethanol screen and some antidepressants. So those are the ones that he felt were really important for his, for helping him to manage his patient. And moving to 21 drugs on that panel wasn't too onerous on our side to make sure that we were able to actually move to this process and discontinue kind of our old process that was really hindering us at that point. So we did a similar process with the other 7 opioid dependency clinics that we had at that time. And so all of them actually had pretty much a very similar backbone of a panel, and then we did a few kind of customizations depending on what they were seeing, particularly in their population. As I mentioned, we added automation steps for this as well, so that we had a robot doing the sample prep, and we interfaced directly to the LIS so that results could be released directly. And so now we can prepare, analyze, and result multiple 96 well plates per day if needed. And we have capacity to handle further increases in our workload volume, which is really important. With our old process, I should mention that we probably, on a good day, and if we had our really experienced technologists doing the data interpretation, we could maybe get 20 to 30 samples out. So this represents a significant increase in our throughput. And over the past 2 or 3 years, we really haven't had any issues with samples piling up because this process is able to allow us to get those samples out quickly. And it allows us to give an LCMS result directly to our clinicians, which I think they appreciate very much as well. So in summary, The opioid epidemic has had significant impacts on healthcare, including laboratory medicine, particularly for us for urine drug screening testing. Immunoassay screens are convenient, but they have major issues in terms of false positives and false negatives. And so mass spectrometry is really such a useful tool for allowing us to monitor parents and metabolites in the sample, to speciate those all out individually and give us a definitive result. And so if you have the opportunity to do mass spec on these samples, I think it really does provide much better information than immunoassay drug screening. Finally, retrospective data mining can help you guide your drug screen panel development if you've got that information, and help open that conversation with your physicians about what might be appropriate for their clinics. So in conclusion or acknowledgement, I'd like to acknowledge Dr. Hossein Sadzadeh, who is my co-director for the Analytical Toxicology Department and also the Section Chief of Biochemistry at APL-Calgary, Dr. Chris Nogler, and of course all of my colleagues in the Clinical Biochemistry Department in Calgary. And with that, I'm happy to take any questions that will be forwarded to me. Thank you very much.